invite the speaker. After the first talk, we will have another moderator. He will introduce Dr. Saraswat, he will introduce Dr. Anil Arora, and after that, we will have a panel discussion, 3 rounds of panel discussion. After that, last 10 minutes, we would like to know more about our faculty, how they really come up to this level. So that will be really inspiring to our delegates who have logged in from all over the world. I'm going to start right now. So we welcome you all, faculty, the delegates, panelists, and the chairperson and moderators. I bring warm greetings from our institute, Medindia Hospital, Chennai. This is being done under the auspices of Medindia Academy, and I take great privilege. It is the honor to be the American College of Gastroenterology, to be governor of India region, and all these webinars have been endorsed by American College of Gastroenterology. And I bring warm greetings from the World Gastroenterology Organization with a scientific committee member, and and I bring greetings from the Dr. MGR Medical University, Tamil Nadu, as the honorary distinct professor. The first two series of webinar, we saw that over 19,000 delegates from all over the world attended. That time, the Corona period, it was really made an impact among the delegates from all over the world. So that really inspired us. Why don't we start? Why not we start the third series of the international webinar series? We are very fortunate. We could get the faculty from all over the world and the best of Indian faculty also, and some from the Southeast Asian countries also. That made us to get the webinar appreciation and the endorsement from American College of Gastroenterology. Now we have planned 12 webinars for this third series from April 2025 to March 2026. And with the tagline, name the topic, the world experts are here. And with the title that new Endo-GE webinar series that created a news here. And the first webinar, the first of the second series webinar was inaugurated by Professor Dr. Jonathan Lighton, with the President of American College of Gastroenterology. He sends his warm greetings to all of us. And one highlight of our webinar has been the participation by Nobel laureate Professor Barry Marshall. He gave a very inspiring talk on discovery, the journey of discovery Helicobacter pylori. And we had seen delegates from all over the world, over thousands of delegates attended. From then onward, we have delegates from the Sri Lanka, Malaysia, Bangladesh, Nepal, UAE, US, and all the have been attending this webinar. And this has been possible with the cooperation from my colleague, in-house medical team, Dr. Gokul, Dr. Satya, Dr. Yogesh, Dr. Prasad, and Dr. Tringana Sambandam. And now what we have designed is 12 webinars. These are the stalwarts from the international, national. The stalwarts have agreed to participate, and they have given their consent so that we are going to have a real scientific feast every month. We have made it fourth Thursday of every month like that. And this again has been possible with this. So many people have already consented to be the moderators and panelists from all over the world. So makes this program very interesting. And we have made a wide ranging topic. What we have designed is here. We're starting with the diabetes, hypertension, diabetes and GI tract, and metabolic syndrome, endohepatology, then dyslipidemia, fat and liver, and the pharmacotherapy of obesity, and endoscopy and surgical management of obesity. This time we are going to have very, very interesting topic like doctor and law, doctor and ethics, doctor and research, doctor and research grants, and doctor and finance, and doctor and entrepreneurship, research methodology. Don't miss this. And how to choose a research question, choosing the most appropriate study design. And the part two will be how to analyze the data and manuscript writing and publication. And we have added a few more very interesting masteral checkup in gastroenterology, precancerous lesion identification, methodology, and management. And February 13, 14, 15, we are going to have a live workshop. I'll be inviting all our ambassadors, faculty, and international faculty for this live webinar. I mean, live workshop. And the last but not least is we are going to have a debate on endoscopy versus surgical management in gray areas in gastroenterology. What is the perspective of a physician? What is the perspective of a surgeon? With this, we'll come to the today's 29th May, where this international webinar. This is going to be a very, very exciting because two important topic. Everyone, and as a gastroenterologist, you see that 30% of Indians are some one time or other they are affected by the systemic hypertension. So, and the same patient has got a cirrhosis of liver. Nowadays, we see massive and liver disease and cirrhosis, obesity, pharmacotherapy, how this combination going to work out and what are the precautions we need to take it. For that, we are going to have two eminent speakers whom we'll be introducing and two moderators I'll be introducing soon. And this program had been possible because of our national ambassador taking real interest from Chaubal, Praveer Roy from Uttar Pradesh, Telangana, Dr. Ramesh, Andhra, Dr. Srinivas, and so many people. It is difficult to name everybody, but they take keen interest in propagating the webinar because of the uniqueness and ACG endorsement. And we have international ambassadors from USA, Malaysia, Nepal, Bangladesh. I'm very thankful for them for taking this kind of interest. Now it's my pleasant duty to introduce the faculty here. The first speaker is Professor Dr. Prabhakar, is a cardiologist. So preventive interventional cardiologist, he works in one of the major corporate sector in India and fellow of American College of Cardiology and Indian Society of Hypertension, co-author of expert consensus statements on the Lipid Association of India list lipidemia management, is a primary investigator and lead of the heart failure registry of Tamil Nadu for the various scientific group, and his current research he is one of the major areas is hypertension, so he will be the best person to talk on this. And to moderate this session, we have equally eminent Professor of Medicine, Dr. S. Chandrasekhar, Stanley Medical College Chief, is a Joint Secretary and Treasurer, Chennai Chapter API, National API Governing Council. We are going to have a API meeting national conference in Chennai in a couple of years, and he'll be one of the lead, the expert in the organizing this meeting, Honorary Secretary of Indian Association of Clinical Medicine, and he is the recipient of several awards and is the Senate member of the MGR Medical University. The second speaker, my good friend, with a very eminent and a brilliant gastroenterologist, is the chairman of Institute of Liver Gastroenterology and Pancreatobiliary Sciences, Sir Gangaram Hospital, New Delhi, liver transplant fellow, Birmingham, and he did his MBBS, MD, DM, all three from All India Institute of Medical Sciences. His areas of interest, apart from the liver disease, therapeutic endoscopy. Now, current interest is stem cell therapy for liver diseases. Several publications he has got to his credit. And who can have a better moderated than Vivek Saraswat, another good friend of mine, is a great speaker and very enthusiastic teacher, professor and head department of gastroenterology. Earlier, he was in Sanjay Gandhi Medical Institute from Lucknow. Now he is in Mahatma Gandhi University School. Medical Sciences in Jaipur, Associate Editor of Indian Journal of Gastroenterology and Journal of Clinical and Experimental Hepatology, Governing Council, member of South Asian Association for Study of Liver. I think it will go on like that because he's got so much to his credit, and he's the honorary secretary for INASL now. I mean, in 2003 to 9. Now we have three panelists now. Dr. Chandramouli, he is in the Department of Gastroenterology from Malaysia, and this is a university, and where Malaysia. He has been very active liver specialist and portal hypertension. And Mohapatra is another good friend of mine, and he is from PGI Chandigarh. He is a consultant gastroenterology, Peerless Hospital in Kolkata. And Dr. Srinivas Rao, very active senior gastroenterologist, very busy gastroenterologist from Aditya Hospital, Rajahmundry, Andhra Pradesh. Now, with this, now I invite Dr. Chandrasekhar to introduce the topic, how important hypertension. At the same time, they invite the speaker to go on with the first speak.
Yeah, thank you, sir. Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. T.S. Chandrasekhar, sir, Med India, and ACG for having me here. As he rightly alluded to, the hypertension is such a common disease, like almost 1 out of every 5 Indian, they may have hypertension. So the incident and prevalence is rising up, like particularly among the adolescent people and the teenage people, people in the second decade and third decade. And we do see hypertension doesn't come alone, and it comes with a lot of comorbidities also. It's always a challenge. Somebody is having a hypertension with comorbidities, and at the same time, there are so many guidelines, like starting with your the American Heart Association, your European Society of Cardiology, our own Indian Society of Hypertension. There are Canadian guidelines. There are so many. The guidelines are there, so to get some kind of the framework on how to manage the patients with the hypertension, how to evaluate and how to treat them effectively. Like we do have with us Dr. D. Prabhakar, who is a eminent cardiologist, and he's a very good erudite speaker and most invited popular speaker. And he is the right person to talk on the systemic hypertension, the management protocol. And he is a senior interventional cardiologist from Apollo Hospital and director of Ashwin's Heart Care Center. So we are pleased to invite Dr. D. Prabhakar to talk on systemic hypertension, the management protocol. Over to Dr. D. Prabhakar.
Thanks, Chandru. Thank you so much. It was very nice introduction to the topic that we had to talk with Professor Chandrasekhar. I want to thank him for giving me an opportunity to be with this erudite audience. I never expected a crowd of 1,000 plus webinar in a webinar nowadays. It used to be in those days when the lockdown was there, but I think still getting a crowd of about more than 500 seems to be enormous task, and 1,000 plus in a multinational crowd. I think hats off to your quality of work that you're doing, and congratulations, and keep the good work going, sir. Without much ado, there has been a good introduction given to the topic of hypertension by my two previous friends who have been talking. And I think I will give you one or two very simple things to tell you about hypertension. Now, basically, hypertension is a very, very interesting topic that is of interest to everybody. The moment you pass MBBS, somebody comes to you and tells you have hypertension. And whenever I talk about hypertension, I love to give this particular statement: the only constant in medical science is change, and nothing is more changed more than hypertension. If you remember the story of hypertension, the first time a blood pressure was recorded was here when Stephen Hales actually put in a tube into a horse and bled the horse to death. That's when he measured the blood pressure. And that was the first time. And subsequently, what happened? Rivaroki found the BP cuff. I think all of you are aware of all these things. But what really was most interesting is this statement that came in the British Medical Journal in 1889. This is what the BMJ had to talk about sphygmomanometers. It says, we pauperize our senses and weaken clinical acuity. This is how the original concept was. Till for the first time in 1979, the Society of Actuaries came up and said that the definition of hypertension was 160/95. Then we are all aware of the JNC came in 1, 2, 3, 4, 5, 6, 7 over the years with different changing guidelines and different drugs of choices. And today, where do we stand in 2024? What I felt, I will take you through a simple case which we see every day. Common garden case, walk you through it so that we all make a good understanding of how we manage hypertension in clinical practice. Simple gentleman, 48-year-old male, non-smoker, social drinker, and father had a stroke at 65. Metabolic profile is normal, 150/94. During a master health checkup, there was nothing else. He keeps checking his blood pressure, and he says the blood pressure is pretty much the same. Now, the question they wanted to ask every one of you, you can think about an answer, because since it's a webinar, if it's a live session, I would have asked you the question, you could have given me an answer. What is normal blood pressure? The commonest answer I keep getting is 120/80. Now, I will answer the question myself. Today, we have come to a definition wherein we say there is nothing like normal blood pressure. There are three categories of blood pressure today. One is hypertension. If your blood pressure is more than 140/90, I'm quoting the European Society of Cardiology Guidelines 2024, and elevated blood pressure between 120 and 140 systolic and 70 and 89 diastolic, and non-elevated blood pressure between 120 and 70. It's very interesting. 120/70 is non-elevated blood pressure and not normal blood pressure. So nobody has a normal blood pressure. There is a justification for what I say. I will keep going in the next slide. Why did we make a diagnosis of hypertension at 140/90? This is very interesting from the HOPE-3 trial, which said only if your blood pressure is more than 140/90, then you have benefit. If you try to start blood pressure medication at a lower BP, it can actually be harmful, as you see in the top panel here. But this classification is more of a treatment classification. It's not a prognostic classification, which is what I meant initially. This is a treatment classification, meaning that you start medication at this particular time. So 140/90 is the definition of hypertension. 120/70 is non-elevated blood pressure. But the risk actually starts at 90 millimeters of mercury. Starting from even 90 millimeters of mercury, as the BP goes up, there seems to be a continuum, which might surprise you, which surprised me quite a lot when I read through this particular statement. So starting from any blood pressure, it goes up. So no longer normal blood pressure. What you have is possibly a non-elevated blood pressure. This seems to be accentuated more among women. There is a little bit of difference between men and women. I will not push through too much into it, just to say that this accentuation of blood pressure's effects from 90 is more often seen in women. The first question you need to ask yourself in your clinic is, what blood pressure apparatus do you use? Mercury is banned, so you're not going to have a mercury apparatus. So what you're going to be using is an automatic apparatus. And to check whether your apparatus is true, please go to the STRIDE website and make sure that you're using an apparatus that is approved by the World Hypertension League, International Society of Hypertension, and European Society of Cardiology. Most of the Omron apparatus and the A&D apparatus available in India are approved. So make sure that you're using an apparatus that is approved by the STRIDE website. The next question is, how was the clinic blood pressure checked? I'm sure all of you are aware of this. I still want to make a few interesting points. Talking during measurement of blood pressure can increase the BP by 4 to 19 millimeters of mercury. Most of the times, this white coat hypertension is not because of you talking, but because of the patient talking. So make sure that it doesn't happen. All the other precautions, back supported, feet flat on the ground, legs uncrossed, elbow rested on the table. Mind you, if your arm is just hanging freely, it could increase the blood pressure. So make sure that the elbow is rested well on the table. And after 3 to 5 minutes of rest, make sure that the blood pressure is taken. Now, there is a big controversy that cropped up. I'm sure all of you must have heard of the SPRINT trial, which said that blood pressure should be measured in a room separately by the patient. Put the patient there for 5 minutes and make him measure his own blood pressure thrice over 1 minute intervals in a room without anybody attending on him. The usual thing we do is a sister or somebody in your assistant recording blood pressure. Now, which is going to be a better methodology. Now, clearly, all of us have understood today that the office blood pressure is the better one in a quiet room. Attended blood pressure is accepted. The main reason was the SPRINT blood pressure could not be replicated in other studies. So if you're doing it in the office with somebody, you're doing the right thing. Please don't change your methodology. That has been going on. Two important points to remember. The patient must be seated for at least 3 to 5 minutes before measuring blood pressure. Most of the time, patient comes, sits, checks blood pressure, it's invariably high. That is wrong way of measuring blood pressure. And how many readings do you take? If you have a normal blood pressure or a non-elevated blood pressure, it's fine. But if your BP is elevated, take 3 readings, and the average of the last 2 readings is important. So it's the average of the last 2 readings that is important. Please remember, don't take 1 reading and say the person is hypertensive. Couple of interesting facts that you have to remember. The first time you measure a hypertension or a blood pressure, make sure you check it in both arms. And in atrial fibrillation, which we see very often nowadays, the prevalence is increasing by the day because the longevity is increasing. You make 3 measurements and take an average of this. There are some automated apparatus which are AF enabled. So you can buy those apparatus also if you're seeing a lot of atrial fibrillation patients. But more interestingly, this might interest all the intensivists. In a hypotensive patient, if you use the automated oscillometric apparatus, the blood pressure is actually 13 millimeters higher. Please remember, it could be higher in a hypotensive patient, plus don't trust that. You have to go in for a manual pressure or an intra-arterial blood pressure to check the blood pressure. So what is the significance of measuring the blood pressure for the first time in a clinic? Simple. If your blood pressure is non-elevated, let's say less than 120/70, there are no comorbidities and the age is less than 40 years, the next BP check is possibly going to be after 3 years. The last panel, look at it here. If your blood pressure is more than 180/110, that is one thing you cannot send a patient home. If the blood pressure is more than 180/110, never send the patient out of your clinic. You have to record a lower pressure or get him into a hospital. In between, you can take your time, confirm your blood pressure, and then start treating these patients over a period of time. Now, most of the time, we keep telling, measure your BP at home. How is home blood pressure checked? The commonest reason why physicians keep telling me that they don't record home blood pressure is, when I ask him to check, he checks the blood pressure, WhatsApps me the message, and immediately asks me what to do. Please don't do that. The way to do it is, last 7 days prior to your visit, ask him to check his blood pressure, or if necessary. Otherwise, you don't have to do it. How do I get rid of this, my hand from there? Give me 1 second. I'll just stop share remove. There's an automatic thing that keeps going up in this. Sorry for that. Right. So I'll go back to my presentation. I think I should not lift my hand. Okay. So what happens is, discard the first day reading and monitor your blood pressure. When do you check blood pressure? You check in the morning and check in the evening. Twice a day, you keep measuring. This is a chart that I use in my clinic. 3 blood pressure recordings, measure the systolic, diastolic blood pressure, and the pulse rate. The pulse rate is very important because that will tell you if the 3 readings are grossly different. Generally, now we are accepting that the first 2 readings are sufficient. In fact, we had put up this paper in the World Hypertension Congress. This paper called the Filament Blood Pressure Study, checking the first 2 and the last 2. It got the first prize award in the World Hypertension Congress, just concluded in Chennai also. And that was showing that 2 BP readings in the first and second is enough at home. While in the office, you check 3 blood pressure readings. Ambulatory blood pressure, there is no controversy. It is one of the best. When to use it, I will tell you. But today we are talking about using ambulatory blood pressure 20 minutes during the day and every 30 minutes at night. Now, basically, you need 14 readings during the day and 7 readings at night to record a meaningful ambulatory blood pressure. Remember that this is going to be absolutely essential to have it. This is how the ambulatory blood pressure reading looks. This is the night time. The rest is the white time. The yellow is the white coat effect. If the blood pressure is only elevated here, it's a white coat hypertension. There should be a normal 10% fall. If you look at this particular patient, the nighttime BP is much higher. There is, in fact, a higher blood pressure at night called reverse dipping. This is one of the patterns of hypertension that you start looking at in these keeper patients. So when do you do an ambulatory blood pressure? When do you do a home blood pressure? Now, there are these patients where you want to measure the nocturnal blood pressure, especially the diabetics and secondary hypertension patients. You do an ambulatory blood pressure. But for long-term follow-up, it is going to be much easier. Encourage the patient to check his blood pressure at least once a week and last 1 week before sort of follow-up. That improves adherence also, and that is going to be beneficial. Home blood pressure monitoring is what I usually recommended, but ambulatory blood pressure has its own benefits also. So primarily, when do you use all these modalities? The home blood pressure and ambulatory blood pressure can be used to diagnose white coat hypertension. What is masked hypertension? Very simple. The reverse of white coat hypertension. The blood pressure is normal in the clinic, but the blood pressure is normal in the clinic, and it is very high during the home blood pressure monitoring or during an ambulatory or 24-hour blood pressure monitoring. That is masked hypertension. So whenever you have a person with a new diagnosis of suspected hypertension without any left ventricular hypertrophy or a hypertension-mediated organ damage, you can do one of these modalities. But you have a patient with blood pressure under control, but again, left ventricular hypertrophy that is happening. Again, these modalities are useful. Anybody with resistant hypertension, whenever you start using more than 3 drugs, encourage home BP or an ambulatory BP, because most of the time there is non-compliance and several other issues which can be detected. The simplest reason why we keep telling you that hypertension and the home blood pressure and ambulatory BP is monitoring is very important to this. It does not happen in patients who are only not a known hypertensive. Now look at this panel. The left, what you see is patients who are not a known hypertensive. The right panel shows hypertensive patients. The white coat hypertension happens in both hypertensive and patients who are not known to have hypertension. So it happens in both groups of patients. Okay. Similarly, masked hypertension also can happen in both groups of patients. So you have to understand that these both groups of patients can have both, and it's a very useful tool. And the prevalence of hypertension is going to be very, very high. And in fact, the number of patients in our study where we had looked at about 748 patients, nearly 45% of the patients, it changed the diagnosis. Looks like our office blood pressure or clinic blood pressure doesn't seem to have much of relevance at all. But what do you do if you have white coat hypertension? Please don't ignore it. Subsequently, they become hypertensive. Lifestyle modification is mandatory. Don't worry, you're only scared of doctors. Please start them on lifestyle modification. It's important. What do you do if there is masked hypertension? Again, it is a very tricky question. But if you have this masked hypertension, you can probably go up on the higher blood pressure. Now, why do you get this masked hypertension? White coat hypertension is fair, acceptable. But masked hypertension is much more interesting. There is actually an autonomic dysregulation and increased vascular stiffness. So when a patient is coming to your clinic, probably that is the best time where he is more relaxed. If the office is very stressed, his BP spikes in office, BP is going to be higher, and you have masked hypertension. Similarly, this effect is amplified when the arterial stiffness is there. Sometimes non-dipping happens in secondary hypertension, and there can be a morning surge. And one of the important reasons that we have found out recently is endothelial dysfunction. So there is an entity called masked hypertension. Start looking at it. And in fact, any well-controlled hypertension or anybody with the target organ damage or a left ventricular hypertrophy, you start looking at this kind of patients and looking at investigating. Now, having suspected hypertension, what investigations do you have to do? Look at these investigations. The basal investigations, the sugars, the lipids, the serum potassium, the renal parameters are important. But what is essential is an urine examination and a 12-lead EKG. The 12-lead EKG, I will just dwell on a little bit more. Now, all these are to look out for one, comorbidities like your diabetes, your dyslipidemia, and your renal parameters. And there is an entity called hypokalemic hypertension. If it is there, send it down to an endocrinologist. We'll talk about when to refer a patient also. The ECG can give you a very important clue, but the cardiologists tend to use this very often to look at left ventricular hypertrophy. Now, why is it important to look at left ventricular hypertrophy in hypertension? Because the cardiovascular mortality is nearly 2 times higher once you diagnose left ventricular hypertrophy. Most of the time, I see that patients have left ventricular hypertrophy. Nobody has told them the importance of it. Please understand, if your left ventricular hypertrophy is there, your mortality is twice higher. And how to look at left ventricular hypertrophy is not the measurement of the interventricular septum and posterior wall. Look at the LV mass index. Encourage your cardiologist to give you a left ventricular mass index, which is the most accurate and correct way of doing it. Does it regress? Yes, over years, it can regress, but it is very rare to achieve regression in women, diabetics, and obese. This is something that we have to understand and make sure that these patients are treated aggressively to achieve some kind of a regression in these patients. Interestingly, what are the ways to regress it medically? Now, the new drug, the SGLT2 inhibitors, has been shown to produce regression. Like it can reduce by 3 to 5 grams. But the most effective drug is the ACE inhibitors and ARBs, MRAs, and the new GLP-1 also can work. But primarily, remember one thing, control of blood pressure is the most important thing in these group of patients. Now, having said this, we'll move on to what the next thing we have to do. Remember, I told you non-elevated blood pressure, hypertensive blood pressure. Now, what do you do for these patients with an elevated blood pressure between 120 and 140 systolic? To treat or not to treat? That's a very big question. Now, what do you have to do for these patients? Now, look at end organ damage and look at patients with kidney disease, diabetes, familial hypercholesterolemia. These are all high-risk patients wherein what you tend to do is start treating these group of patients. One slide that's missing. That you have to start treating these patients. Now, apart from these patients, you also have to do one important thing. After you rule out this, there is something called the sex-specific risk modifier. This is the most ignored thing. Among women, gestational diabetes, gestational hypertension, preeclampsia, 1 or more stillbirths, miscarriages, all these are very, very important subsequent markers for coronary artery disease. Now, if you see these patients, start treating them at an elevated blood pressure, risk stratify them and start treating them early. This is something very, very important. Remember these women-specific risk factors and start treating these group of patients. There's 1 or 2 slides got jumbled up. Now, once you start diagnosing hypertension, once you decide to treat, remember I said about lifestyle modification, we are all aware of it, but one thing you remember is increased potassium intake. Rest is all pretty well known. Increased physical activity, weight management, and restriction of salt are pretty much known to each one of you. Now, this particular patient comes back to you. It's not much of a hypertensive when you checked him up. He comes back to you, let's say 6 months later, with a blood pressure of 140/90 consistently. Now, you have also checked your home blood pressure. Again, that is high. Now, what do you do for these patients? Do you start him or do you not start him on drugs? Remember the mantra here. Once you diagnose hypertension or suspect hypertension, if he is hypertensive, within 1 month, you start medication. Within 3 months, you should achieve control, and long-term adherence is important. So initiation, implementation, persistence, all three have prognostic value. So remember to start drug early, control in 3 months, and adherence is important. What are the drugs available? Several groups of drugs are available. Those that act on the salt mechanism, like the diuretics, those that act on the peripheral vascular resistance, like the calcium channel blockers, the beta blockers, and the sympathetic nervous system, RAS inhibitors, where there you have the the ACE inhibitors and the angiotensin receptor blockers, like the losartan, valsartan, telmisartan, that are available. Now, all these drugs, any of these drugs can be used, but what we say now is all the 4 drugs can be used as much as you want. I will come to that in a second, but one drug I want to highlight. If you don't have any tests, the blood pressure is high, the general practitioner's drug of choice is going to be a calcium channel blocker. It's the safe drug. You can give it in renal failure, you can give it in hepatic diseases, you can give when the potassium is high, you can give it in asthmatic. I think the general practitioner's drug, if you don't know anything, do a calcium channel blocker. All others require some kind of monitoring, and be careful with the other drugs. Now, should you wait till the blood pressure goes more than 140/90, or should you not wait? Now, you have to wait, because you have to remember that the blood pressure at a lower pressure, you don't start drugs in elderly patients more than 85. If the patient has orthostatic hypotension, frail people, and if the patient has got some severe comorbidity, like let's say malignancy there, you don't give them any of these drugs. You have to be really careful with those patients. Wait till the blood pressure really comes. Now, should you give 1 tablet or 2 tablets? Now, this is Moses coming here. If you see, Moses came originally with 3 tablets, and when he was walking out with 3 tablets, he dropped 1. Typically, this is what happens to patients. You give him 3 tablets, he's going to drop 1. So Moses, even in those days in cartoons, took 2 tablets, linked them into 2. So you give 2 pills in 1 tablet. So this is the mantra for hypertension also that keeps working today. You give a combination therapy. It improves compliance. The effect is complementary, low dose polydrug therapy. Side effects are less because the dosages are less. And most of the patients, once you start medication, they don't come back to you because they don't have symptoms. So unless you give a combination therapy, the BP never comes under control. Why? I will tell you in the next slide when I tell you. So what is the best combination? What is the recommended combination? Low dose combination of a RAS inhibitor, ACE inhibitor, let's say ramipril or a telmisartan with a calcium channel blocker is usually the preferred drug. If it doesn't get control, add a diuretic. But what do we do more often? We start using a beta blocker in India. But there are specific indications for beta blocker. There are this is what I call as the happy indication for beta blockers: heart failure, angina, atrial fibrillation, post-myocardial infarction, and a young woman planning pregnancy. Now, these are 5 indications that are going to be definitely used for a beta blocker. Apart from that, there are a few other indications. Now, whenever you use a combination therapy, it's fine. Now, the mantra is to use a combination therapy. But when do you use a single pill therapy, single pill, single drug therapy? Grade 1, low risk hypertension, younger patient, where you don't want to be very elderly, frail, where you want a slow reduction in blood pressure, orthostatic hypotension, or high normal blood pressure, like those that the category of non-elevated or elevated blood pressure, where you want a mild reduction in blood pressure, there you can start thinking about it. Now, practical question that everybody gives is everybody splits drug into morning, evening, everything we keep giving. Now, when do you time these medication? When you give in the morning or evening or night? We used to say those days morning, evening. Now we are very clear. You ask the patient at any time he wants. It doesn't matter really, but he should take it every day at the same time. So it can be morning or evening, polypill therapy in the morning, polypill therapy in the evening, anything is fine. So give a combination and give it together. When we started these medication, what is the target you're expecting? Now, for the first time, the European Society of Cardiology came up with this beautiful number, said your target blood pressure is 120 to 129 and 70 to 79 diastolic. That's a very, very interesting number. 120 to 129, which we never achieve in clinical practice. We treat from 140/90 and treat up to 140/90. Please understand, ladies and gentlemen, you're treating your patient wrongly. Bring down your blood pressure correctly. Now, this is something that came up in one of the talks, and I looked up and got the answer. What happens if I'm on a combination of telmisartan with amlodipine, 40 and 5 milligram, and this is the blood pressure that I get, 105/86. You're saying 120 to 29, 70 to 79. What should I do for this particular patient? Should I bring down the blood medication or should I go up on the medication? This is something that irked me. When I looked up literature, this thing came up. The systolic blood pressure is the most important thing. Getting to 120/29 systolic is very important. And especially in the elderly, even if the diastolic blood pressure is controlled, go for the systolic only. Additional reduction of diastolic blood pressure does not carry any additional benefit. But in younger individuals, less than 40 years, you can try to achieve diastolic blood pressure control. In the elderly, the policy is what the radiologists use, ALARA, as low as reasonably achievable. This is very, very important slide. If you're taking one single message from the entire talk, I will say this is important. The systolic blood pressure is more important. Try to achieve 120 to 129. And remember that in clinical practice, don't keep stepping up your drugs. So in this particular patient, once your systolic is there, this gentleman was 65 years of age. What I did, reduce the amlodipine actually, and his blood pressure brought the systolic to more than 120 systolic. That's very, very important. Now, if you look at this particular study from Jack, which was published this year, this shows that the sweet spot is 130. Beyond 130, the mortality rises. So even in the very elderly, 80 plus, you can bring down the systolic blood pressure to 80 if they tolerate it. I think that is going to be very, very important for you to treat this. 1 month later, he comes with 144.80. You add a diuretic, like I said. And among the diuretics, please understand, chlorthalidone is preferred. Don't go for a higher dose of chlorthalidone, because the higher the dose of diuretic, it activates the renin-angiotensin system. It will be counterproductive. Indapamide is a drug of choice when the very elderly, more than 80 years. And if controlled on hydrochlorothiazide, please don't have to change to chlorthalidone. Leave them on hydrochlorothiazide. That's also a very important thing that you have to remember. 3 months later, on a triple drug combination, 134/78 with a heart rate of 90. What are you going to do? Now here the key is going to be the heart rate of 90. Will you accept a heart rate of 90 in these group of patients? Now it is very clear that whenever the heart rate is more than 80, there is increased sympathetic activation. Beta blockers can be indicated. Now this is new because at any stage of hypertension, it is useful to give a beta blocker. And if you look at this panel, you see that the top panel, high heart rate BP uncontrolled is the worst. Look at low heart rate and the blood pressure, that is the heart rate of less than 80 and the blood pressure control has the lowest event rate. Look at the next one, uncontrolled BP with a lower heart rate. So looks like the heart rate less than 80 is very, very important, more important than the blood pressure control. Please start reducing that. Combination therapy, I already alluded to and told you these are the drugs to be used. You can use these combinations in any way you want and try to achieve blood pressure. Now, if you're on 3 drugs and if you don't control, preferably these 3 drugs, calcium channel blockers, RAS inhibitor, and the diuretic, and the blood pressure doesn't get controlled, you make a diagnosis of resistant hypertension. So how do you approach resistant hypertension? I'll just give you just one slide on this. Look at serum potassium when you are more than 3 drugs for hypertension. The serum potassium less than 4.5 or more than 4.5. Less than 4.5, use an MRA like spironolactone or an eplonterone. More than 4.5, look at the heart rate. More than 80, give a beta blocker. Less than 80, start using an alpha blocker. I think very simple algorithm for management of hypertension. If you go by this, most of your patients are controlled with hypertension. Now, when there is renal failure, there are a few caveats that you have to understand. One important thing is if your EGFR is less than 30, use a loop diuretic, not the conventional diuretic. But among the diuretics, the chlorthalidone seems to be working better. Also, if you are going to use a regular diuretic like the chlorthalidone or hydrochlorothiazide. Less than that, I don't think more than 30, you don't have to make much of arrangements. You don't use much of spironolactone or MRA because of the fear of hyperkalemia, and frequent monitoring is going to be very, very important. There are a lot of new drugs coming. ARNI, the new drug that is there, has been extensively used, but the interesting point is ARNI is dosed once a day in hypertension. SGLT2 inhibitors, finerenone, the newer drugs like aprocitentan, zilebesiran, all reduce blood pressure by nearly 10 to 20 millimeters. The last one, the zilebesiran, is very, very interesting because it reduces angiotensinogen synthesis. The most interesting part is that it is going to be given once in 6 month injections. So this is going to be coming in probably in the next 1 year. If it comes, or a patient comes to your clinic, once in 6 months injections, he's going to be all right. So when do you refer a patient to a specialist? Now, those patients, wherever you have secondary hypertension suspected. Now, when do you suspect secondary hypertension is very, very important. Uncontrolled hypertension in a patient who is less than, anybody is going to refer, but younger patient less than 40 years. Formerly, we used to say less than 30. But if it's less than 40 years with grade 2 or 3 hypertension, you try to look out for secondary hypertension. Whenever there is an electrolyte imbalance in the initial onset, uncontrolled hypertension, true resistant hypertension, anybody presenting with hypertensive emergency, sudden deterioration of hypertension, you start looking out for secondary hypertension. This is just a key chart to show you which age, what happens. Younger age group, all the congenital disorders start happening. The renovascular hypertension starts happening after about 41 years of age. But there is another category of fibromuscular dysplasia that happens in younger group of patients. This is when to refer a patient. Now, this slide always interests everybody whenever I post this, because this slide is actually the drawing room of my house. All these liquor bottles are there. It's a collection from my dad's place. And there are two sayings that are there which interest everybody. The greatest enemy of man is alcohol, but the Bible asks us to love thine enemy. I'm sure the gastroenterologists won't agree. He who drinks gets drunk. He who gets drunk goes to sleep. He who sleeps does not sin. He who does not sin goes to heaven. So let's all drink and go to heaven. This is the saying that is there. But what does it do to the heart disease? Benefits of moderate alcohol consumption compared to abstinence has been very small but consistent, but not fantastic benefits. Can be there. But even 30 or 45 grams of alcohol is going to be about 1.5 pegs a day is associated with increased cardiovascular risk. So ultimately, bottom line is you don't try to give alcohol. So that brings us to alcohol and liver disease. So liver disease, what do you do? There are two kinds of interesting interactions. One is liver disease like hepatitis, NAFLD, and cirrhosis. Two is the pharmacokinetics, what it does to the metabolism of the drugs. Those which albumin binding, increase free levels of drugs, both are involved. But I will try to make this part very, very simple. What is the interplay between portal hypertension and systemic hypertension? If you look at portal hypertension, it actually triggers a systemic inflammation, endothelial dysfunction, and increase portosystemic collaterals. Both these can increase blood pressure. Contrary to the belief that you have hypotension, your hypertension can also increase in portal hypertension. In systemic hypertension, there is an hyperdynamic circulation which can actually worsen the portal blood flow and increase your portal hypertension also. Now, what is the difference in the management when you have this systemic and portal hypertension? Loop diuretics are given for congestion, not the conventional chlorthalidone or hydrochlorothiazide, and spironolactone is the drug of choice here because more data is given there. When it comes to beta blocker, whenever you have portal hypertension, the hepatologists love using carvedilol or propranolol. Nowadays, it's become purely carvedilol, and you generally don't start it during acute variceal bleed. I don't have to teach you how to use this. And you generally start at a low dose, and you see more hypotension than hypertension. But usage beyond 12.5 is very questionable because of only hypotension. Heart rate up to 55 you can accept. Nothing will happen. Heart rate up to 55 may be beneficial, but don't go below that in any of these patients. So what about the drugs? You try to avoid a few drugs. Methyl dopa has a risk of hepatitis. Hydralazine actually accumulates in cirrhosis, which one of the third line or fourth line drugs, try to avoid it. And verapamil, diltiazem, which are the non-dihydropyridine calcium channel blockers, have an hepatic metabolism, try to avoid them. Nitrates have a risk of hypotension in liver disease. It's going to worsen, so be careful with them. The third one is the safe drugs. Which are the safest drugs? The RAS inhibitors, the ACE inhibitors and ARBs have a renal clearance and can be used safely in liver disease. But probably the safest drug among the lot is going to be amlodipine, very freely available, very safely used in this. So to summarize whatever I have told you about hypertension specifically, in a diagnosis of hypertension, 140 is the systolic blood pressure. Less than 120, non-elevated blood pressure. Between the two, you have elevated blood pressure with different categories, the sex-specific risk factors. Look at that and start treating these patients. Once you start treating this patient, your optimal target is going to be 120. Try to aim 120 to 129 systolic. Above that, probably some specific group of patients like the elderly, frail, so orthostatic hypotension start looking. Anything goes beyond 140, 160, be careful. More than 180, look at hypertensive emergencies. That's a different ballgame. I'm not going to touch that together. Now, thank you very much for the opportunity and for the patient listening. I hope I haven't exceeded time, and I think I will stop sharing. Thank you very much, sir.
It's indeed good entertaining by Dr. Prabhakar. I think we thank you, sir, for the insights, the recent insights on how to evaluate and how to treat the patients. Of course, you are nicely dealt on the patients with chronic liver disease, with hypertension also. I think we can have a couple of questions in the later part of it. I think I hand over the podium to Dr. T.S. Chandrasekhar, sir, so that we can have the panel discussion and the questions from the delegates at the end of the session. Over to
Professor
Dr.
Chandru,
T.S.
I would agree with you that when you introduced Dr. Prabhakar, is one of the most sought after speaker in the country. So he really did great justice to the whatever the topic and they covered it very well. I like the drawing room very much, the way you brought it at how the sin and okay. And what is more important is systemic hypertension need to be taken care. Sometimes you have a slight elevation of this diastolic blood pressure. You don't want keep on increasing the pressure. Okay. With this, we will move on. We'll have a lot of questions. We already have so many delegates who asked around 40 questions, but we'll choose some questions will ask you. And the second speaker we already introduced, Professor Saraswat. We will introduce the topic, and he'll invite Dr. Anil Arora to give the talk on pharmacotherapy of portal hypertension and cirrhotic and non-cirrhotic. And after that, we are going to have the combination of systemic hypertension, portal hypertension, how we are going to manage this. And I welcome Professor Anil Arora and Professor Saraswat to start the proceeding.
Okay. Thank you, TSC. Good evening, everyone in the audience as well as the panelists. Professor Chandrasekhar has already introduced Anil right in the very beginning of this session. However, I'd still like to say a few words since I've known Anil for over 40 years, since our DM days at the All India Institute of Medical Sciences in the 1980s. Even during his MD and DM days, Anil was a prolific writer and had a lot of publications to his credit, which we all envied in those years. Now he is the leader of a team of prolific writers at Gripmer. So much so that it would not be an exaggeration to say that his department is one of the top 5 academic institutions in India publishing high quality papers in hepatology, as well as a slew of INASL, Indian National Association for the Study of the Liver, guidelines and consensus statements. Now, today Anil is going to talk to us about portal hypertension. As we all know, portal hypertension is a central feature of chronic liver disease. It can be of many types: pre-hepatic, hepatic, post-hepatic, and lately a few apparently new entities like portosinusoidal venous hypertension or venous disease has come in, which looks like old wine in new bottles. We know this entity as non-cirrhotic portal fibrosis and a couple of others, and hopefully Anil will touch upon this at some point during his presentation. Portal hypertension is the chief driver of complications and progression in patients with chronic liver disease. Everything from ascites to variceal bleeding to hepatic encephalopathy are related to portal hypertension. And we have a number of interventions and lines of management for this condition, including prophylactic therapy, which is usually with non-selective beta blockers that we'll hear about. And in case of active bleeding or active decompensation and complications due to portal hypertension, various pharmacologic, endoscopic, and intervention radiologic options are available. Ultimately, liver transplant is the panacea for all patients with chronic liver disease. But one needs to keep in mind that one may not get completely rid of portal hypertension even after a successful liver transplant. So with these few words, I would like to invite Anil. The floor is yours, and we look forward to listening to your take on portal hypertension and its ramifications. Anil.
Anil, please.
Thank you, Dr. Vivek. And I'm extremely thankful to Dr. TSC for giving me this opportunity amongst a very august gathering. And I'm also proudly privileged to be speaking in front of my teacher, mentor, Professor Vivek Saraswat, who was responsible for putting me in the field of hepatology way back in our golden days of studies at AIMS. So I'll just share my slides.
You have any problem, then please, because it's a regular Zoom platform only.
Yeah, and somehow.
Okay. You have the sharing option there down.
Yeah,
just
share.
go down. Yeah, share. Yeah, there you can share.
Yeah.
You already opened your slide, no? PowerPoint.
Yeah.
Yeah, okay.
Okay, my slides are visible now.
Not now.
Can you see my slides?
No, not well. They are not on the screen yet.
And okay. The window. You have opened the PowerPoint now.
Yeah, my PowerPoint is
You
open.
go to the share and entire screen. Are you seeing something on the screen now? Me and you on the desktop.
Yeah.
Yeah, there. You
One
have
minute.
to.
I'm not able to see this.
Keep the PowerPoint open on the desktop and minimize it and keep it ready.
Yeah.
Open the PowerPoint, minimize it, keep it ready. Then you go to
Don't
the
use
share
the full
button.
screen. It might be hidden there if you are using the full screen. So the green thing you could minimize.
First, open your
PowerPoint is,
and minimize it.
yeah, minimize
Then
it.
you click the share button.
Yeah.
You click the share button.
Yeah, it shows me.
No, sir.
Yeah. You share that green one arrow there, no? Let's share that.
You got
Yeah, when I share, it shows me entire screen.
no, end screen. Okay, sir.
It
Select
shows
it.
Okay.
entire.
Or you send it to me, then I will.
I'm going to click on it.
There you click it there.
Yeah, shall I send it to you?
Yeah, you send it to me right now in the,
Okay.
my email ID tscmedindia@gmail.com.
Let's click on it. Just
You click the share button now. You click the share button.
1 minute.
Sir, you already opened that your PPT in the desktop, sir.
Yeah.
You already opened it, no, sir?
Yes.
Now you have to come back to the Zoom, sir. Zoom.
Yeah, I'm in the Zoom.
Yeah, then you have to click the share button, sir.
Share, yes. It
Yeah.
shows me application window, Finder.
No, sir. And then you have to click that screens. Then there will be 3 options: screens, document, and advanced.
You click the screen one.
1 minute.
Okay. Or you send it to me right now. I will share it with you.
Okay. I'll just share
Okay.
it.
While you are doing that, we'll keep taking the questions from the.
Yeah.
Once we are ready, then we'll come back to you.
Okay.
Dr. Prabhakar, we have some interesting question.
Yes, sir.
Dr. Chandru, you want to start the question now while he is ready for that? But Prabhakar, end also will have a lot of questions.
I'm good, sir.
Okay, right.
Yes, sir.
Okay. Now, Chandru, you want to start the question now?
Yeah, yes, sir. Let us begin with you mentioned about the various the guidelines, like how we can approach to a patient with hypertension. So the one of the paramount and the most important thing one has to do is the lifestyle measures. So of course you touched upon the lifestyle measures and the importance of it. That is the only one that can give a double-digit reduction as equal to a antihypertensive. Can you elaborate on some DASH diet and what are all the physical activity? Because most of our hypertension patients are elderly. They may not be able to do kind of the exercise prescription for those kind of elderly people. Can you enlighten on this, sir?
That's a very important aspect. I didn't want to go through it because this is an elite audience of consultants. So I didn't want to teach them how to do a lifestyle. Very simple measures are going to be important. The first thing that you start doing in looking at is your intake of salt. Your salt intake of about 2 grams, which is a sodium intake of about 5 grams. So it's going to be there. And what you simply do is avoid excess salt. That's the simplest thing that you could do. Don't add any table salt. Don't add any kind of salty foods like chips, papad, the pickles that we use very often in South India. Avoid those things is one important thing. The next important thing in the diet is going to be, you mentioned something about the DASH diet. DASH is a very specific diet. It actually means dietary approaches to stop hypertension, wherein there are a few interesting concepts. One important concept is going to be, importantly, to try to increase the fruit and vegetable intake, which increases dietary potassium. If you remember my slide, I would have told you that increase potassium in your diet. Now that is also coming up when you start increasing fruits and vegetables, and you also increase calcium in your diet. That also reduces your blood pressure. Contrary to the fact that we give calcium channel blockers, this dietary calcium actually can reduce your blood pressure. The third important thing in your diet is basically the DASH diet also talks about using plenty of fruits, vegetables, nuts, legumes, and all those things. And they try to avoid the basic rice. So it's actually a pyramid wherein they tell you eat more of these foods that are going to be healthy, multiple fruit helpings, multiple helpings of nuts every day. It says about 4 to 6 helpings of fruit, 4 to 6 helpings of vegetables. And basically it means one thing, very simple. Increase more fruits, vegetables, come down on the rice, come down on the basic meal, and increase adding up this. Don't add the snacking, cut out the snacking, take healthy food. In addition to that, your physical activity comes next. Physical activity, important thing. What is recommended is 150 minutes of walking per week. If you're going to be jogging, 75 is enough. In 3 sittings of 25 minutes each is fair enough. But what we miss is the weight training. That's very, very important. Twice a week of weight training is going to prevent your hunch from happening. And you are also improves your heart and your muscles also. That is something that is missed. That also has to be done. Apart from these 2 measures, smoking, there's no question about the fact that you stop smoking. Simple, stop smoking. Even vape can increase blood pressure. So don't talk about any kind of smoking. Next is the alcohol intake. Okay, moderate alcohol consumption can have a vasodilatory effect. But when you start taking alcohol, at that point, BP comes down. But the next day morning, there is a rebound increase in blood pressure. And binge alcohol intake can also increase atrial fibrillation and create a problem. Simple dietary modifications, lifestyle modification, avoid stress. It's very easily said than done. All these things are going to be very, very effective. I will not go too much beyond this, Chandru.
Yes, sir. Nicely illustrated. Yes, sir.
Yeah. Only thing is the alcohol you insisted very much. But sometimes binge alcohol can produce pancreatitis also. I have seen people coming just before the marriage, the wedding party, and the bachelor's party. They take alcohol. They come with the severe pancreatitis. They have to stay in the hospital for a few months also, and they postponing the marriage or they abandoning the marriage also. With I think you have covered the diagnostic criteria of hypertension very well. And you also covered that the secondary hypertension, when to refer the patients and recommended investigation for a newly diagnosed hypertension. And you are given importance to the potassium also. And we have 3 questions. Some from the you are ready now. We will put up again the question, Dr. Prabhagar. Sorry for the some hiccup here. And we will go to the full screen, Anil.
Yeah, I have changed my laptop.
Oh, that's okay. Luckily, you did not change the topic.
No.
Okay, right. We'll start now. You can go to the slide mode. Yeah, very good. Fantastic. Okay.
Yeah.
Saraswati is going to start, Dr. Anil. Okay.
Yeah, with you.
Yeah. First of all, thank you everyone for bearing me with the technical glitch. I hope Dr. Chandrasekhar and Dr. Vivek, my slides are visible.
Yes, they are.
Yeah, the topic which is allotted to me is drug therapy of portal hypertension and non-cirrhotic portal fibrosis. In patients with cirrhosis of the liver, there is a downward spiral when a disease advances from a stage of chronic liver disease, compensated chronic liver disease, to a decompensated liver disease. And then in the form of decompensation, you have add-on features of ascites, hepatic encephalopathy, and variceal bleeding, leading to further decompensation, culminating in death unless the patient is transplanted. Now, in a patient who does not have any sort of decompensation, the median survival is as good as a normal individual, that is 10-year, 90% survival. But the moment you start having first decompensation in the form of either ascites or hepatic encephalopathy or variceal bleeding, there is a plummeting of survival from 10 years to 2 years. Subsequent further decompensation rapidly culminates in mortality. And reason for all this, as mentioned by Dr. Vivek, is the development of portal hypertension. What is portal hypertension? If you just look at the anatomy, most of the splanchnic circulation gets drained through the portal venous system. When the portal vein joins, the superior mesenteric vein joins the splenic vein to form the portal vein, which enters into the liver. Any rise in the portal pressure leads to ominous complication, which clinically presents either as GI bleeding, tense ascites, or hepatic encephalopathy, which we are so used to seeing on day-to-day basis. Since the portal vein is typically located deep into the abdominal cavity, away from the hawk eyes of a clinician, it's not easy to get into the portal vein through the normal route. And hence, we tend to put in a free catheter into a catheter, ball-tip catheter into the hepatic vein, wedge it into the hepatic vein, and then see the difference between the wedged and the hepatic venous pressure. And that gradient between the two is the gold standard for diagnosis of the portal hypertension. In fact, the Leonardo da Vinci, as way back in 1500, did describe patients who had something like portal hypertension. But the very term of portal hypertension was coined by Gilbert Carnot way back in 1902. As of today, we know any hepatic venous pressure gradient of up to 5 millimeters is supposed to be normal. Portal hypertension is defined by a HVPG of more than 5, between 6 and 9. Any pressure of more than 10 millimeter mercury is called clinically significant portal hypertension, which has its own risks and the ominous complications. The moment you have a portal pressure or HVPG of more than 12, you're likely to bleed. And all of us know that if you are harboring a portal pressure or a HVPG of more than 20, we are likely to have a refractory bleed. How do we measure portal pressure if we do not have the facility of invasive HVPG monitoring? There are laboratory tests, imaging modalities, endoscopic means, and the vibration controlled transient elastography or fibroscan, which gives us clues and methodology to diagnose raised portal pressure. And taking all this into account, the recent Babino 7 has given us clear-cut guidelines of non-invasive tests to tell us what is a clinically significant portal hypertension or an advanced liver disease. Now, anybody who has an LSM or liver stiffness measurement of more than 25 is likely to have, almost 100% likely to have a portal pressure of more than 10 millimeter mercury. If you have a LSM of less than 5, you are absolutely normal. You do not have any significant fibrosis. So it is the readings between 10 to 15 to 20 in which you can take the ancillary help of the platelet count and concomitant factors to diagnose whether the patient has a clinically significant portal hypertension or not. Why is it that we are so obsessed with trying to look at the liver stiffness measurement, or for that matter, HVPG? Because we know the moment you have clinically significant portal hypertension, the moment you have an LSM, which is a non-invasive assessment of clinically significant portal hypertension, there is a 5 times increased risk of decompensation. Not only that, every single millimeter rise in HVPG increases the risk of decompensation by as much as 12%. In addition, we know the moment you have raised portal pressure, the most ominous complication is development of varices. Once they bleed to the tune of about 10 to 15% per day, per year, depending upon the size, the CTP class, and the presence or absence of the stigmata of the recent hemorrhage. In spite of the fact that we have been treating portal hypertension for decades, even today in 2025, the 6-week mortality of variceal bleeding continues to be about 25%. And most of the patients who bleed once from the portal hypertensive variceal status, they are likely to rebleed to the tune of about 60% of the times over the next 2 years. So based on that, Babino again has tried to classify the portal hypertension depending upon presence or absence of the clinically significant portal hypertension as assessed either by LSM or by demonstration of raised pressure by invasive test of HVPG. So compensated cirrhosis means either you have mild portal hypertension or you have a clinically significant portal hypertension without varices. Now, the survival in this subgroup of the patient is very good, and you have a excellent survival so far as the patient does not decompensate. But with passage of time, as the portal pressure rises and the varices bleed, there is a first decompensation, or patient tends to develop ascites or hepatic encephalopathy. You have a rapid downhill course, and further perpetuation or further occurrence of these events leads to rapid increase in the mortality in the form of mortality in the form of death unless transplanted. So clinically significant portal hypertension is an extremely important pivotal event in the natural history of patient with liver disease. So what is that clinically significant portal hypertension, and what is portal hypertension? As we know, this is the portal anatomy. You have the portal vein which enters into the liver. It tends to get in conjoined with the hepatic artery. It goes into the sinusoids. From there, it is drained via the hepatic veins into the portal, into the systemic circulation through the hepatic veins into inferior vena cava. So the obstruction to the portal system can be in the prehepatic region because of the different reason mentioned. It can be within the liver, which is the commonest cause of portal hypertension, primarily characterized by cirrhosis. And then you can have a obstruction beyond the level of the liver in the form of either sinusoids or post-sinusoidal obstruction. All of these will lead to attendant complication of portal hypertension. Let's talk of something which we see most commonly, and this is also called Poiseuille's law. Whenever you have portal pressure, it is primarily determined by two things: the portal blood flow and the resistance. And whenever you have a diseased liver, because of the distortion of the liver, because of the deposition of the fibrosis in the sinusoids, you are likely to have increased intrahepatic resistance because of the architectural changes, because of the fibrosis. In addition, in patient with chronic liver disease, you are less likely to have vasodilator and more likely to have vasoconstrictor within the liver. So liver is giving you a persistent resistance to the flow of the liver. As the blood flow which is coming into the liver is getting obstructed, so that is perceived as decreased blood flow coming into the liver. So the peripheral vasodilatation occurs, that leads to a decrease in the systemic vascular resistance. So two things are happening at the same time. So you have increased resistance to the flow of the portal blood into the liver, that leads to increased pressure. In addition, because of the accumulation of the blood and peripheral vasodilatation, you are having decrease in the vasoconstrictor and increase in the vasodilators in the splanchnic circulation. So because of the increased vasodilatation in the splanchnic circulation, more and more blood flow is coming. So a vicious cycle is occurring. You have increased resistance leading to increased portal pressure, and you have increased flow. So this combination is something which results in portal hypertension. The increased resistance occurs because of the structural changes, whereas the dynamic changes occur because of the systemic hypotension occurring because of the peripheral vasodilatation, as well as because of the increased vasodilatory substance which tend to be present in the splanchnic circulation. So you have 70% of the portal hypertension which occurs because of structural component, and dynamic component in the form of either decrease in the nitric oxide or increase in the vasoconstrictor is responsible for 30% of the portal hypertension. Mind you, the drug therapy which we are going to talk of now, which is the topic of the day, will only look after the dynamic component because it cannot do anything to the structural component. So what do we do in patients who have established portal hypertension? Our aims are very clear. If you are having a non-invasive testing, our aim should be in a patient who already has a compensated portal hypertension, do something so that this guy does not get decompensated. In a patient who is already decompensated, make all efforts so that it does not decompensate again and it remains in the first compensated state. So the purpose of treatment of medical therapy of portal hypertension is to prevent further decompensation. So there are two sets of drugs which are available for treatment of portal hypertension. One is the drug which is causing structural damage to the liver, that is the etiological therapy. Then you have a group of the drugs which will give you reduction of the portal pressure, or the general therapy. Now, drugs which are known to cause changes in the etiological therapy will depend on what was the reason for development of portal hypertension. You have hepatitis B, C, alcohol, or NASH, whereas general therapy will aim at reduction of the portal pressure. In fact, in the early stages of the cirrhosis of the liver, when etiological factor is trying to take care of the injury to the liver, you have etiological cure of the disease. You treat for hepatitis B, you treat for hepatitis C, you stop alcohol and treat NASH, there will be some reversal of fibrosis. But as the disease advances, because of the increasing flow and increasing resistance, you may not be, the etiological factor may not be reversible, and hence you have to bank upon the medical therapy. Does etiological treatment of portal hypertension affect? The answer is a big yes. 50% of the times, patient with hepatitis B, they tend to recompensate over the next 2 years if you give them good antiviral therapy. There is also good data in hepatitis C to show that in patients who are being treated for hepatitis C, not only 35% of the patient may have recompensation, but even the portal hypertension as assessed by HVPG can have substantial reduction. In fact, 35% of the patient may have loss of CSPH, clinically significant portal hypertension, and antiviral therapy. Once you are beyond the stage where structural changes can be undone, you have to bank upon all modalities to reduce the portal pressure. So you have short-term treatment of portal hypertension in the form of terlipressin or antibiotic, or you can give long-term therapy in the form of either beta blockers or the statins. Portal hypertension by default, again, as I said, can be reversible component in the form of dynamic changes occurring because of the vasoconstriction in the liver and vasodilatation in the splanchnic circulation, or a dynamic component. As I said, our beta blocker therapy is primarily taking care of the dynamic component of portal hypertension. I think we should salute to this man called Dr. James Black, who in 1902 discovered this drug called propranolol. There is a difference between an invention and a discovery. Discovery or invention is something in which you go and discover something which was never available. Something like propranolol, it was a drug which was discovered to block the beta receptors by this gentleman called Black. He had done this after the sudden death of his father from a heart attack. He was basically a pharmacologist who was trying to study the effect of various receptors onto the heart and their contractility. All of us are pretty aware of this seminal and pivotal publication by Dr. Librex way back in 1980s regarding the utility of propranolol in treatment of portal hypertension. You'll be surprised to know that this gentleman had only 8 patients compared to 8 placebo, and he convincingly showed that just giving propranolol will lead to 30% reduction in the portal pressure. Just to recapitulate, what are the beta receptors? There are 3 types of beta receptors: beta 1, beta 2, and beta 3. Beta 2 receptors are located in the smooth muscle of the bronchus. They are on the smooth muscles of the splanchnic circulation, in the bladder, as well as in liver for glycogenolysis. Beta 3 tend to occur in the peripheral circulation. Beta 1 is primarily located in the heart. So what do these receptors do? So basically, it is a presynaptic terminal which releases this neurohormone called epinephrine. And once the B1 receptor is stimulated by epinephrine, it leads to tachycardia, increased cardiac output, and increased renin secretion. Beta 2 stimulation by norepinephrine leads to bronchodilation and smooth muscle relaxation. So what our drugs propranolol and carvedilol do is they block beta 1 receptor and hence cause bradycardia and decrease cardiac output. And beta 2 block will lead to peripheral vasoconstriction of the smooth muscle. So they will block the vasodilatation of the smooth muscle in the bronchus, as well as in the splanchnic circulation. And then you have a carvedilol, which is a drug which primarily acts on the intrahepatic sinusoidal relaxation by antagonizing the alpha receptors in the systemic circulation. So the 2 drugs which are commonly available to us as hepatologists for treatment of portal hypertension include propranolol and carvedilol. Propranolol is basically a propanolamine, which is a single ringed structure, whereas a carvedilol is an aryl ethanolamine, which is a double ringed structure. In addition, carvedilol, unlike propranolol, comes in 2 enantiomers, S enantiomer as well as the R enantiomer. So what they do is, these drugs, propranolol it is a non-selective beta blocker and acts on both beta 1 and beta 2 receptors. Whereas carvedilol has, in addition, an antagonism for alpha 1 receptor also. So the blockage of the beta receptors which are basically beta-2 receptors, are equally distributed in the splanchnic and peripheral circulation, whereas alpha-1 receptors are more concentrated in intrahepatic sinusoids. So by default, you have an advantage of blocking the beta blockers in the splanchnic circulation so that you have decreased blood flow in the portal circulation, and at the same time you are blocking alpha receptors in the liver so that you have decreased resistance. So you have a dual advantage of decreasing the resistance and decreasing the flow. So that will be commensurate with the Postula's law so that you have a reduction of the portal pressure. Something most of us do not try to appreciate is that there is some basic difference between alpha and the beta blocker. If you give a drug like carvedilol, it is available in 1-to-1 ratio of S enantiomer as well as R enantiomer. Now, in a normal course of the event, when you give the drug, 90% of the S enantiomer, which has a dual advantage of alpha and beta blockade, is transgressed in the first pass hepatic metabolism. But in patients, so that you have only alpha blockage, which is of use by decreasing the portal pressure within the liver. Now, in a patient who has an advanced liver disease, what is happening is the liver is not working. The first pass metabolism of the carvedilol S enantiomer does not occur. So you have an S enantiomer which is giving you alpha blockade, as well as you have a R enantiomer which is giving you an alpha blockade. So you have a twin alpha blockade which comes from the partly metabolized S enantiomer and completely available R enantiomer. That is the reason in advanced stages of the liver disease with portal hypertension, if you are giving carvedilol, you are more likely to have potent alpha antagonism and more likely to have hypotension, and hence the dose of the carvedilol has to be decreased in them. Do we have comparison between the two molecules? Answer is yes. On weight to weight basis, carvedilol gives you lesser reduction, more reduction in HVPG. It is more likely to lead to decreased varicose rebleeding. The chances of decompensation are also less, and overall this drug is much better as of today compared to propranolol. Is it superior as of today to propranolol in decreasing HVPG? Answer is yes. For primary prophylaxis, it has been shown to be non-inferior to propranolol, and for secondary prophylaxis, now we're having more trials that this drug is supposed to be superior to propranolol in terms of efficacy, both in prevention of first bleeding, in prevention of the second bleeding, and decreasing the incidence of the first decompensation in the form of ascites. So what these drugs ultimately do is propranolol and carvedilol both will decrease the cardiac output. Beta blockade will cause splanchnic vasoconstriction, thereby decreasing the blood flow into the portal circulation. Carvedilol on its own will lead to intrahepatic sinusoidal blockage, leading to decrease in the hepatic resistance. So a twin advantage of decreasing the flow into the portal system and decreasing the resistance ultimately it leads to 35% decrease in the portal blood flow with the currently available beta blocker therapy. Is it possible to assess this hemodynamic response and efficacy? You can assess it either in the form of chronic response, which is assessed by reduction of the HVPG by more than 20%, or to an absolute value of less than 12 millimeter, or you can even do an acute response by looking at the response to intravenous propranolol or carvedilol by looking at a more than 10% reduction. The answer in both the clinical scenario is almost the same. It has also been shown that if you're able to reduce HVPG to less than 12, or if there is a more than 20% reduction in HVPG from the baseline, both these conditions would mean that you have effective response to beta blocker therapy. A patient is with, say, particular drug like propranolol may not be able to respond to a single drug. So can we shift him over to carvedilol? It has been shown that 57% of the patients who did not respond to propranolol will have substantial and meaningful reduction in HVPG if you shift them over to carvedilol. And if both of these are not useful, then you can switch on to EVL as the first line therapy for control of the portal hypertension. Moreover, it has been shown if you compare carvedilol versus propranolol, it is more useful for reduction of the portal pressure, it leads to lesser variceal rebleeding rate, it leads to lesser further non-bleeding decompensation in the form of development of ascites, and it has been shown to decrease the mortality. This is just a comparative chart of the degree of the portal pressure reduction by various drugs which are available. Carvedilol, being the most potent, decreases the portal pressure by 20 to 25% compared to terlipressin 17 to 18%, propranolol to the tune of 10 to 15%, and statins and metformin are other drugs which are going to talk to you soon about. So propranolol and carvedilol are very good drugs in prevention of the first bleeding. All these societies, ASLD, EASL, and Bebino 7, clearly state that there is no role in pre-primary prophylaxis. The reason is, at this time, the sympathetic system has not been activated. That means there is not enough vasodilatation in the peripheral circulation to activate the sympathetic system. As soon as the disease is advancing and you are developing clinically significant portal hypertension, both propranolol and carvedilol are useful in 50% reduction of first variceal bleed and decompensation when used as a primary or secondary modality. For prevention of the first variceal bleeding, whether you're using propranolol or carvedilol, there is a 50% reduction in patients who are either having high-risk varices or clinically significant portal hypertension. For prevention of secondary bleed also, Bebino 7 recommends that given the choice, carvedilol is supposed to be more potent than propranolol. And this is a summary of almost all indication in which beta blockers are better than placebo for prevention of the first decompensation, for prevention of the first variceal bleeding, for prevention of the various rebleeding, for prevention of the bleeding-related death in patient without previous bleeding, for prevention of death in patient with previous bleeding, and even in patient with ACLF and patient with gastropathy, there is some data to show that beta blockers are of use to drug. So what else do these drugs provide other than reducing the portal pressure? They decompensate other events in the natural history of portal hypertension. They lead to 30 to 40% reduction in the incidence of the ascites. They also decrease bacterial translocation and prevent SBP in patients with ascites. They have additional carvedilol especially has additional antioxidant properties. And when given in lower doses, it has been shown to improve survival in patients with cirrhosis of the liver. In a patient with cirrhosis of the liver, by default, there is a decrease in the motility of the gut because of the sympathetic overactivation. And as the disease progresses, you have more and more stasis of the gut. So with blockage of the sympathetic system, you are more likely to have increasing gut motility so that the bacteria do not stay in the gut. So the translocation of the bacteria decreases. In addition, most of the patients with portal hypertension do have a leaky gut. In patients who are having a healthy gut, you are more likely to have predominant anaerobes in the healthy gut. So in presence of the decreased motility because of the sympathetic overactivation, in patient with cirrhosis of the liver, you have altered microbiota and you're more likely to have predominant aerobes in lumen of the gut. So a combination of the altered microbiota and decreased motility predisposes to the transmigration of the bacteria, leading to increase that LPS getting into the portal circulation and then increasing the portal pressure in the circulation. In fact, this Predsky trial published in 2019 clearly shows that simple addition of propranolol in patients who are tolerating or carvedilol in patients with who are not tolerating propranolol certainly leads to 50% reduction in development of the first event, primarily in the form of prevention of ascites. Do we need to monitor the dose or we just give him a standard dose? In fact, it is always important that we have to step up the dose and see that how these patients are tolerating. So we graduate, at least in propranolol, it has to be a stepped up dose. You start with lower dose. Depending upon the tolerance, you have to monitor the heart rate with the aim to maintain a heart rate of 25 to heart rate of about anywhere between 50 to 55. In fact, even though the literature mentions a maximally tolerated dose of 320 milligram per day, Dr. Vivek would agree with me, most of us will never cross a dose of about 80 milligram per day. What about carvedilol? Carvedilol being more potent of the two certainly requires recommendation for starting at a lower dose of 3.5 1 to 5 milligram and gradually build up to a maximum of about 6.25 milligram twice a day. Suffice it to say that higher doses only will be detrimental for the patient, and the maximum dose which is recommended is 12.5 milligram per day, preferably in 2 divided doses. And this dose has also been shown to reduce the development of ascites. So the basic thing which we need to remember about propranolol or carvedilol is that you have to have stepwise escalation of the dose to have a meaningful maintenance of the MAP, which is so important for maintaining the integrity of the kidney in a patient who already has a diseased liver. Adverse effects tend to occur in 15 to 20% of the patients who are on beta blockers. And this is the EASL diagram, which clearly shows that up to 15% of the patient, because of the sympathetic overactivity and the side effects of the beta blockers of the sympathetic system, they are likely to have fatigue, dizziness, hypertension, GI disturbance, etc. And the drug may have to be discontinued. All of us as seasoned physicians are pretty aware of the established contraindication, which include a significant heart block, peripheral vascular ischemia, cardiogenic shock, or asthma, which are absolute contraindication in patients with cirrhosis of the liver. There are also some relative contraindication which we have to know. Do these beta blockers have limitation? Answer is yes. We have in patient with advanced liver disease, if you are using a potent beta blocker like carvedilol, you are likely to have some problems. So 3 situations which demand a careful appraisal by a seasoned physician include patient with refractory ascites, bacterial peritonitis, and ACLF. In fact, there is something called window hypothesis. I think no talk on beta blockers can ever be complete unless you look at the nuances of so-called window hypothesis. In the early stages of the disease, when sympathetic system is not stimulated, because there is not much peripheral vasodilatation, beta blockers do not act. In the late stages of the disease, when the heart is so much stimulated that depression of the contractility of the heart by beta blockade will lead to further decrease in the portal in the systemic blood pressure, leading to decreased flow to the kidney. So you have a local window, or you have a specific window which opens for a short period of time. So this is a peculiar concept of utility of beta blocker that you have to judiciously use in the middle stages of the cirrhosis, when you have a clinically significant portal hypertension, but not the advanced disease in the right for adequate utilization of this. So what do we do in patients who have limitation of utility? We tend to avoid carvedilol. We give propranolol, which is not as potent alpha blocker as carvedilol. We try to decrease the dose of conventional dose of propranolol from say 160 or 320 milligram to 80 milligram per day. If need, we may have to temporarily halt it during the time of infection, like in SBP or during AKI, or you can look at alternative therapy. So in a patient who has refractory ascites or AKI or recent ALF, ACLF, what we recommend is you try to stop carvedilol, switch on to lower dose of propranolol, and if the patient does not tolerate it, it's better to stop, because at later stages of advanced liver disease, any more alpha-1 antagonism is going to be more detrimental than of any utility. So as of today, ladies and gentlemen, is it worth sticking to beta blockers? Answer is big yes. They provide effective primary prophylaxis for variceal bleeding at a very low cost compared to EVL. They prevent multiple endoscopic procedure for variceal eradication and risk of bleeding from EVL-induced ulcers. If used efficiently in lower doses in decompensated cirrhosis, especially carvedilol, it has been shown to improve survival. Apart from providing bleeding prophylaxis, this group of the drugs are also known to decrease the bacterial translocation and hence concomitant infection and further rise in the portal pressure, which is triggered by the activation of the stellate cells and the myoblasts within the liver. And they also decrease the decompensation by decreasing the portal pressure. And they are a useful adjunct in patients who bleed from portal gastropathy or entropathy. Statin is a new upcoming drug, which because of its multitude of action in the form of anti-inflammatory action, anti-fibrotic action. This is a drug which is known to cause increase in the vasodilator substances in the liver, thereby helping the alpha blockade, and also has anti-cancer effects. In fact, it has been shown that statins can be used in almost all cases, especially in patients with NASH, for different indications for reduction of the portal pressure. And it is said that they reduce the portal pressure to the tune of about 10 to 15%. There is some data to show that the incidence of HCC also decreases in patients who are being put on statins, and it has been shown that because they also have effect on the lipids, they also lead to decrease in the cardiovascular events. So what is the lesson for us to use statin in patients with the liver disease? As of now, the hepatotoxicity because of the statin is mild and transient and rare. It is safe to be used in patients with compensated cirrhosis. It should be avoided in patients with advanced liver disease, and you have to be careful and cautious, and you have to take it with a grain of salt if you are using it in child B and child cirrhosis. In fact, a lot of studies have shown that simvastatin in the dose of 20 milligram is safe, effective, decreases the variceal bleeding, decreases decompensation, and in the liver hope study, it has been shown that it also improves the hepatic fibrosis. Terlipressin is a drug which is useful for reduction of the portal hypertension by decreasing the splanchnic pulling in a subgroup of the patient with AKI or hepatorenal syndrome given for a short period of time to a period of 2 weeks. There are other drugs like midodrine or other major vasoconstrictor which are of use in subgroup of these patients with hepatorenal syndrome. Suffice it to say that for only very recently, the world has been using terlipressin, including us in India, for almost 2 decades. But it was only recently, after the advent of the confirmed trial, US FDA has approved the use of terlipressin for the first time in patients with hepatorenal syndrome. There is a new concept of anticoagulation to prevent decompensation. It has been recently shown that if you try to increase the patency of the portal vein, you will have a more blood flow which will go into the liver and try to maintain the structure and integrity of the liver. But as of now, anticoagulation is meant only for a subgroup of the patient as per the Baveno 7. In subgroup of the patient who have either a symptomatic portal venous thrombosis, or who have recent onset portal vein thrombosis, or the patients who are destined for liver transplantation. Short of that, across the board use of anticoagulation is still not permitted. Metformin is another good drug which, because of the multitude of action by decreasing the hepatic stellate activation, by acting as a anti-inflammatory agent, and by improving the insulin sensitivity, has been shown in animals model to decrease the portal pressure. And retrospective studies have shown that not only decreases the portal pressure venous gradient, it has been shown to be of use in preventing development of hepatocellular carcinoma, except that it should not be used in patients who have advanced liver disease. In patients with gastric variceal bleeding, it is the treatment of choice is endotherapy, but beta blockers as drug therapy as an adjunct, because they not only prevent rebleeding, they also prevent the other complication occurring as a part of the portal hypertension. In portal hypertensive gastropathy, even though mechanical techniques are important for taking control of the bleeding patient, and non-selective beta blockers are an important adjunct as they reduce the portal pressure, which is the positive problem for these issues. Similarly, in portal hypertensive enteropathy, you should be able to do mechanical jobs like APC and bending, but portal hypertension, but addition of beta blockers is certainly a useful adjunct. Not only would it decrease the pressure in the portal system, which is causing these bleeding areas, but it will also prevent the further decompensation in these patients. The role of beta blocker in NCPF and EHPVO, there are no randomized trials. Suffice it to say, where we should treat them as per the recommendations of GI bleeding in a non-cirrhotic, in a cirrhotic individual. To sum up, ladies and gentlemen, cirrhosis has 2 prominent phenotypic stages. You have a compensated cirrhosis, and somewhere down the line, when clinically significant portal hypertension develops, you have portal hypertension, which is so important an issue in causation of the decompensation, and there is a substantial change in the survival from 10 years to 2 years the moment you have clinically significant portal hypertension. Hepatic venous pressure gradient is the gold standard for diagnosis of the portal hypertension. But because it is invasive and it has its inherent limitation for assessment of the disease process and for repetition and reputation of the results, there are number of invasive test to come and tell us as to what is the degree of HVPG, especially the LSM and the other parameters which are available give us equally good clue to the presence of significant portal hypertension. There are the drugs which are meant to treat portal hypertension can take care of the etiological agents like the drugs meant for hepatitis B, C, and NASH. Whereas if in the early stages this are of quite an immense use, but the moment you have advanced liver disease and significant fibrosis, you have to bank upon the drugs to reduce the portal pressure. Beta blockers, non-selective beta blockers, and now the advent of carvedilol, which again is a non-selective beta blocker with an additional alpha blockade, are the mainstay of the therapy in portal hypertension management. Carvedilol has scored head and shoulder above the propranolol because not only it leads to higher reduction in the portal pressure, but it also is more useful in subgroup of the patient who do not respond to propranolol, and also decreases the increases the survival if used in judicious way as mentioned earlier. Non-selective beta blockers, preferably carvedilol, should be used in all patients with CSPH, not only to prevent variceal bleeding, but also to prevent the development of the first decomposition like ascites, as has been shown by the Predisky trial. And in advanced liver disease, you have to be cautiously using beta blockers because in the setting of AKI, refractory ascites, and SBP and ACLF, the liver reserves have got exhausted, and further reduction, especially with the use of carvedilol, will further lead to reduction in the blood flow to the kidney, thereby compromising the efficacy of portal hypertension management and aggravating the problem of AKI. Terlipressin and midodrine are useful adjuncts in advanced disease. Metformin and statin are the new drugs on horizon which have been shown to reduce portal pressure. With that, I'll stop sharing my slide and hand it over back to the organizers.
Well, Anil, thank you very much. That was a very thorough and extensive review of the topic of portal hypertension. And by the way, very nice slides. You have given us comprehensive insights into the nuances of beta blockade in portal hypertension, carvedilol versus propranolol, some newer drugs, and other modalities for the management of portal hypertension. And in the end, in your summary, you have summarized all the important points that you have listed in your talk. So, TSC, I think we can probably go ahead with the Q&A.
Yeah. We can start with the first. We'll give a chance to the panelists first. So, Anil, fantastic slides and very comprehensive discussion about where we need to stop the carvedilol and where in decompensated advanced cirrhosis, how propranolol can be used it. And it's a fantastic message you have given it. And we are very, very lucky to listen to you. And we'll start with Mahapatra. You have a question to my speaker, Dr. Prabhakar. And before he starts asking, I want to ask Prabhakar, do you ever use carvedilol for your systemic hypertension? Or
no, sir. My usage of carvedilol is restricted to patients with heart failure where the blood pressure is on the higher side.
So we only use maximum the people at the portal. Okay, with this message, Dr. Mahapatra, Dr. Srinivas, and Chandramouli. Then we'll come back again to Saraj. Mahapatra, you have to unmute yourself. Please unmute. Srinivas, you want to ask question before Mahapatra? Yeah, Mahapatra.
Yes, yeah. So, I think Srinivas, you can go ahead with the question.
Yeah. What is the effect of beta blockers and EVL on portal pulmonary hypertension?
Question to Anil.
Yes.
Okay.
Yeah.
You see, in fact, it has been shown that portal pressure reduction, especially tips, will not lead to any change in the portopulmonary hypertension or in the hepatopulmonary syndrome. If you look at the pathogenesis of both the entities, they are different. Portopulmonary hypertension, there is an extensive thrombosis in the portal system leading to increase in the pulmonary arterial pressure and the right-sided failure. Whereas in hepatopulmonary syndrome, there is an extensive pulmonary arteriovenous shunting leading to hypoxia. Both of these have nothing to do with the portal pressure. They have to do more with the problems of altered thrombogenic substance landing into the pulmonary circulation or mismatch between the vasodilators and the vasoconstrictors within the pulmonary circulation. And hence, primarily for reduction of these two, beta blockers are not useful. And hence, TIPS is also not used in either of the two conditions.
Okay. I think well said. Mahapatra, what is your question? And all of you, the ambassadors, and be ready.
Anil, one thing I
Yeah.
have to ask. That confirmed trial you mentioned, it's basically albumin with a doliprane. So basically a type 1 hepatorenal syndrome.
Yeah.
So yeah, that was only for type 1 hepatorenal, that confirmed trial, no?
Yeah, that's right. You see, after all, type 2 hepatorenal syndrome is basically an end-stage liver disease which requires liver transplantation. You are talking about type 1 acute hepatorenal syndrome, in which if you get the blood from the circulation, from the splanchnic circulation back into the peripheral circulation so that you increase the blood flow to the kidneys, that is a basic purpose. So it is useful, I agree, and only in type 1 hepatorenal syndrome.
Type 1 Dr. Chandramouli?
Yes, I have a question. See, after this is for Dr. Anil.
Yes.
Yeah.
Can you hear me?
Yes,
yeah.
yes.
Yeah. After diagnosing the cirrhosis, for the portal hypertension, are you doing regularly the non-invasive test like transient elastography, or you depend on the clinical findings, or do you do regularly OGDS to find out the portal hypertension?
Yeah, you see, once you have portal hypertension, which is evident to you, either by clinical judgment or by radiological means, you only start treating it. You do not, if you have varices which have bled, then obviously you have to see to it that they have been eradicated by your EPL, because after all, propranolol alone in secondary prevention is not enough. You have to couple it with endoscopy. And then as recommended, every 6 to 12 months, you will have to see what is happening to the varices. Fibroscan is a very important modality, because when you are treating the patient for cirrhosis of the liver, you are also most of the time looking at the etiology, especially with NASH, with the hepatitis B, C, alcohol. And in my practice, I find it very useful adjunct that if you have made the patient lose weight, if you have corrected the diabetes, if the patient has stopped alcohol, if you keep monitoring their LSM, which is an indirect parameter of underlying portal hypertension. So this gives a confidence not only to me, I think it is pretty reassuring on the other party also. So they are convinced that what is happening is right.
Okay. Dr. Nirmal and Dr. Vivek Sandeep, you have a question? Dr. Nirmal? Yeah, Dr. Praveen, you have a question to Dr. Prabhakar?
Yes, sir. Yes, sir. My question is to Dr. Anil Arora, sir. Is there any definite, sir, can you hear me?
Yeah, you're all here.
Is there any definite guidelines available for usage of statins in cirrhosis?
Yeah.
You see, I give you an excellent review of what statins do.
Yes.
So they have they have pleiotropic effect. They have antioxidant effect. They decrease the portal pressure. They decrease the stellate cell activation. They increase the intrahepatic vasodilators in the form of nitric oxide, and they have antimitotic activity. The only problem is, if you remember in earlier days, the conventional teaching, Dr. Vivek would agree with me, that statin was a big no-no in liver disease, especially for general physicians. They'll just never use it. Subsequent data analysis did show that statins would cause rise in enzymes, but they were not detrimental. So that lurking doubt of hepatotoxicity in cirrhosis because of the statin still is, I think, continuing. And I've shown you the data that risk is pretty minimal. So in child A and B, you can use it safely. But even today, Bevino says that we need more randomized trial to recommend it as a portal hypertensive reductive medicine across the board, like beta blocker. But if it is indicated for other reasons, like dyslipidemia or metabolic syndrome, you're jolly well allowed to use it at your will.
Yes. Thank you.
Can I ask a question? Dr. Chandrasekhar is not there. This is Dr. Prabhakar here. So this
please go ahead.
statin and liver disease. What we say is that when any stable liver disease, you can start a statin. So that's not going to be a problem at all, especially when the cardiac risk is very high. I'm talking from a cardiologist perspective, seriously. So in liver disease with statin, the pleiotropic effects you are talking very heavily. But now, off late, the concept with statins and heart disease is that we find that the reduction of LDL cholesterol is more important. Whatever we said as a pleiotropic effect seem to be happening whenever the LDL cholesterol is lowered. So it is not that, because once ezetimibe came, it started working. PCSK9 came, it started working. Once inclisiran came, it started working. Bempedoic acid came, it started working. Everything is working. So ultimately, reduction of LDL seems to be important. Any concepts on LDL cholesterol here in this particular scenario?
There is no specific data of specific reduction of cholesterol and its relationship to reduction of the portal fibrosis. What I have stated is that, as I mentioned earlier, our apprehension at the level of the physician was that statin will cause raised enzyme, and the moment even the patient is afraid of having raised ALT after you have started a new drug, so most of the people will withdraw. So that has been proven to be wrong, and it has been shown that it is just a minor elevation in ALT, and you can safely use it if it indicates. As of today, also Babino 7 says that across the board, like in beta blockers, we should be given across the board if there is no contraindication. There is not enough data for statins. We need more research on that.
And just to add to that, what you are saying, Anil, I think there is no clear-cut evidence in our hepatology literature regarding a correlation between LDL-C lowering and anti-fibrotic or anti-portal hypertensive effect of carvedilol, of the statins. And again, I think most of the data in statins in liver disease is with the simvastatin rather than the more commonly used rosuvastatin, atorvastatin, etc., which most cardiologists seem to prefer. So maybe that question is worth looking at. When nobody has looked at it, then the LDL-C correlation lowering is worth looking at.
That's exactly what I was driving to, sir.
Yeah, actually, the last 3 slides of Anil, you summarized it very well, the role of statins in liver disease. And now, Professor Chandra, your second round starts.
Yes, sir. Yes, sir. So I got a question to both the speakers. We do have in cirrhosis, cirrhotic cardiomyopathy is one of the complication which is rising up. Like in that situation, what is the role of these beta blocker, non-selective beta blockers? That could be really challenging for any physician. Because we do have a setup, tertiary care setup where the transplant cases are being referred to as. So we do have DCLD patients with multiple comorbidities. So in that situation, how to go about with these the beta blockers?
Okay, before the speakers answers, a small request, we have 12 minutes. Hereafter, the rapid fire and very brief answers. So the question to the speakers from Professor Chandra. Dr. Prabhakar, what is your take? And Dr. Anil.
The cardiomyopathy patient comes with cirrhosis, it's an end-stage cardiac disease, he's a candidate for cardiac transplantation. I think by the time its cirrhosis happens, he's a candidate for cardiac transplantation. Carvedilol will probably be the drug of choice when the portal hypertension is high, but otherwise the blood pressure is going to be very low, whatever is tolerated. The problem with carvedilol is that it can reduce blood pressure because of its vasodilatory action. So I would personally prefer bisoprolol.
Okay, Anil, your take?
Can I ask one question?
Dr. Mahapatra, just wait, we are coming in the circular fashion. You will get after the Saraswat.
There are two ways of looking at it. You can have a cirrhotic cardiomyopathy which is picked up on the routine investigation like echo or sophisticated test on echocardiography. Second is a frank congestive heart failure related to cirrhotic cardiomyopathy. As Dr. Prabhakar said, if you have a frank clinical CHF, then obviously nobody is going to use it. But if the patient has only ECG or echo changes suggestive of cardiomyopathy, I'll still give it in a smaller dosage. Again, propranolol or not carvedilol.
Okay.
But if it is a frank clinical thing, I'll not give it.
Now, Professor Saraswat, your questions or your comments?
Well, I think many of the questions have been covered by Anil in his presentation. So a few questions which may be left unanswered, the more practical ones we can take up. Say you have a patient with cirrhosis and portal vein thrombosis, which is particularly about 30% of cirrhotics may develop portal vein thrombosis, and there are large varices with red color sign. So there is an indication for anticoagulation for the acute thrombosis, and when you have large varices, you are always apprehensive of bleeding on anticoagulation. So how would you proceed in this patient?
Deadly combination, huh?
Yes.
Portal vein thrombosis, bleeding, and hypertension. All this.
And large varices.
Large varices and red stains also there. So now, Anil, is your take.
Yeah, I think my take will be, if there is an urgency and impendency of treating the with anticoagulant acute portal vein thrombosis, I will like to put the patient on beta blockers and not venture with EVL. The reason is, if I start doing EVL, I am likely to produce post EVL ulcers, especially when you have a high pressure in the portal system because of portal hypertension as well as a superimposed portal vein thrombosis. So the incidence of post EVL ulcer will be high. So if the patient bleeds, I will not be able to continue anticoagulant at least for 2 to 4 months. So that is how I'll decide. I'll put the patient on beta blockers. And
So
then
you go for the beta blocker, no EVL, and you continue the anti-thrombotic agent.
Quite a challenge there. You see, what happens really is that your anticoagulants will be effective only in the acute stage of portal vein thrombosis, which is the first 4 to 6 weeks. Once you've crossed 2 months of portal vein thrombosis, then you're not going to be able to recanalize the portal vein. And
But
if you have on top of it large varices, it becomes a real clinical challenge. And again, guess case by case, we'll have to proceed. Maybe what Anil is saying, that you use beta blockers to lower the pressure, and whatever help it gives you,
But the
maybe good enough
problem
in
here
60,
is you have red
70%.
stains, no?
But if the
That's
patient
why-
bleeds, then you might be forced to use, once
you have
you've
the red stain
initiated
and
that
bleed,
stop
yeah.
anticoagulation, and use EBL.
Mahapatra, your quick question, and
Yeah, I wanted to
can
ask
you keep
that,
the mic closer to you? Okay.
yeah. Is there any role of anticoagulant being used as primarily to reduce the portal pressure? Is there any study like that, or just mention, because Anil mentioned that anticoagulant has effect to reduce the pressure, portal pressure?
yes, in fact,
Without thrombosis, huh?
No thrombosis.
Okay, right. What is your take, Anil?
yeah, there is absolutely no indication. In fact, this is a theoretical proposition, because after all, if you see advanced liver disease, it is a very precarious state. And on one hand, you are worried about development of the bleeding, and on the other hand, you are having a prothrombotic state. So prophylactic anticoagulant as of now is not recommended unless the patient has a past history of portal vein thrombosis or you have a known thrombogenic state. Short of that, it should not be given.
Okay, any other ambassador question?
Yeah.
I want to take last 5 minutes.
To Dr. Prabhakar.
Okay.
To Dr. Prabhakar.
No, anybody who has not asked questions so far, Dr. Nirmal, Dr. Vivek Sandeep, or anybody else, Dr. Greece. In that case, I need 5 minutes to wind up this. So Mauli, you want to ask last question?
Yeah, Prabhakar.
Quick question to Prabhakar.
What do you think about the secondary hypertension? The age, any proper history, or any particular physical finding? Do you think that will click to think it is a secondary hypertension?
Chandramouli, with your thing, this is outside the subject, so we will confine ourselves to the systemic hypertension. I'm sorry to interfere here because we have only 6 minutes. Now we will go for the lighter side to know more about my faculty. What is the last lifestyle modification you have done in the last 1 month, Dr. Prabhakar? Now we know, we think about, we keep dealing with all these things. So what is the thing? Okay, this is, I have not done it. I will do it from January 1st onwards, which you are able to do that.
So it's going to be a very interesting answer. Last 1 month, I put on 3 kilos of weight. If it is called a lifestyle modification. Reason is very different. I developed a back sprain.
Very quick.
I developed a sprain in my back and put on 3 kilos of weight.
Oh, okay.
Chandru will be able to recognize me with a 3 kilos weight gain.
Okay,
Yes.
Chandru is a sportsman. He's got a broad shoulder, and he played for Tamil Nadu for cricket team in the among the medicos. So, what is the lifestyle modification? You are already fit and fit as a
Yes, sir. Yes, sir. I started doing some kind of music, indulging in learning guitar and other things. So that's a kind of thing.
I'm talking about guitar. Okay, for the lifestyle exercise, weight and other thing. Okay,
he's talking about lifestyle modification to get a new girlfriend. That is
okay, Anil, that will add more stress to your family. That is very important. Maybe initial maybe okay, but adding more stress, like you said, no, they carved you will have a initial vasodilatation. After that, you will have a stress-induced vasoconstriction like that. Anil, what is the modification you did?
I thought
Apart from doing endoscopy, more endoscopies.
I was told by Dr. Vivek that ideal weight should be 5 centimeter, 105 minus your height in centimeter in males.
Okay, okay, that is all known. What did you do?
I have been.
That means most of us are hesitating. Means we are not doing it. There's no other.
I've been trying to do it, but sooner or later you get stuck up with academic work and you're not able to pursue your.
What did you do? I'm asking. The last one.
What I did,
Not enough.
it was I have been trying to learn dance by looking at.
Okay, you wanted to. What about Saraswat? You?
Well, I think not just last 1 month, last few months, I've been doing more of these resistance exercises using elastic bands for strengthening muscles. Once I've got good enough strong muscles, then maybe I'll do jogging and more vigorous exercise. But at the moment, just muscle strengthening activities.
I think that one thing none of us are concentrating. In fact, he made a passing remark in a lecture that you want to prevent hunch. You do this kind of weightlifting or small exercise, resistance exercise. Many of the doctors, they for the namesake or they just want to avoid some stress. Whenever you talk about exercise, they do like this. That's all. That's the only exercise we do. Or they keep walking and moving around. And somehow we don't spend that 30 minutes a day. I think the moral of the story is we should be the perfect example for the others before we tell this. Number one. And any other once I start asking questions, they disappear from the screen. What about you, Srinivas? What did you do? Srinivas and Mauli, Vivek Sandeep, Nirmal, what? Yeah, quick. I did. I'm planning or I have not done it. What is it?
So I'm doing now swimming.
Okay, but you are not telling confidently. Okay,
No,
maybe you will be doing it. Okay, I will ask. Okay, swimming. Okay, Anil already. Praveen, what did you do? The exercise or the lifestyle modification? Praveen is very silent. He's thinking. What about Bidan from Nepal? Did you do anything in the last 1 month? No. Dr. Sahin from Kashmir, what did you do? Everyone is very silent. That means Sitaram from Nepal. Arvind, you are a very very fond of all these exercises. What did you do, Arvind?
Yes, sir.
He's
For the
from
last 3
Bangalore.
months, For the last 3 months, I've lost 7 kgs. I've completely cut down on rice and for the afternoon and dinner, and a lot of fluids, liquids, and basically salads. And every morning I'm running around 6 kilometers. So I'm down to 70 now from 77.
Okay.
And my passion is singing. Every night I sing. 45 minutes I sing.
You sing. That is a respiratory exercise you do. I think he gets the first prize among all the faculty.
Oh my
you're
goodness.
telling all that. What about Greece? What did you do? Greece, first unmute yourself. Because the reason why I am telling you, there is a status available among the doctors. Their lifespan is shorter than other people, the doctors. So we have to take more care for our health, and we have to spend after the health. After that, only happiness. Then comes the hope. Then comes humor. All the 4H, I always follow it now, right now. So what about Sahin? What about Sitaram? And Nepal, what did you do for physical exercise or the lifestyle modification?
Sir, actually, I gained weight,
Okay, then you are not qualified.
but
you are not qualified.
I gained weight, sir, 2-3 kilo with the family holidays, but thereafter I have reduced it.
No more academies. Only the health is important. What about Akande? You are from Nigeria, and what?
Yes, I do treadmill and also do fitness dance. I do this every other day.
Okay. Now the question I want to ask finally is, what is the quote, the famous quote you really get inspired? You want to tell us, starting from Prabhakar.
Don't trouble unless trouble troubles you.
Okay, you are a cardiologist, preventive cardiologist. What about Anil? Your quote?
My quote is, Do not get overjoyed, for it may cost you more than happiness.
You are become a philosopher. You have every reason to be overjoyed for the kind of practice you do. And what about Saraswat?
I guess the relevant here to this discussion all this evening would be practice what you preach. We preach a lot to all our patients about exercise, diet, lifestyle. And as you brought out very nicely, most of us are neglecting our lifestyle initiatives. So
I
let's
always tell
what
my
we preach.
patient, if you don't find time for doing exercise, you don't find time for keeping your health perfectly, then you will find more time in the hospital.
Yes.
So this is what the
You have
time
to make time for
management.
hospital.
And what is the Chandru? What is
Yeah, yes, sir. So
famous
I
quote
would
you
like
do?
to give you a quote like being still and quiet for a few minutes in a day. So that definitely will calm your mind and you can break from the external input
So
and
that is
it
the kind
helps
of
to connect
meditation
to
you are
yourself.
doing.
Yes,
The
sir.
kind
Yes,
of
sir.
meditation. Okay,
Yes,
okay.
sir.
What about Arvind and Greece?
Okay. Sir, I can sum up in 3 words. All right.
Okay.
What I've learned in life. The
Who
life
is
goes
talking
on.
this? Who is talking? Arvind. Okay, okay.
Arvind
You are
Gubi.
not visible.
Oh, okay. I'm so
Okay.
sorry. Okay.
Okay.
Yeah.
Right, right. You
So I
sum
can
up.
sum up in 3 words. All right. The life goes on. And to live is the rarest thing in the world. And life is a long lesson in humility. So just don't leave life, celebrate life. Yeah.
So you just immediately disappeared and saw in the Google and come back, I think.
No, sir. No, not at all.
A very lengthy quote.
Okay.
Okay, Greece.
Absolutely no.
Will we end up with the Greece? Then I will
Sir,
summarize.
my suggestion that we should sing and listen to these songs so that we can relax ourselves. This is music therapy to go for a healthy life, sir.
But
And
first, my take is physical fitness, then mental
yeah,
fitness, relaxation.
yeah,
All
yeah,
this
yeah.
is very important. If you don't set the weight and you don't check your BP as what he discussed, and don't check your blood sugar, don't check your cholesterol, and all these things. That maybe always there is something to tell about relaxation in the mind. But if you are physically not fit, then you will not relax anything. So, ladies and gentlemen, we have come to the end of this session. The systemic hypertension is so important, and decisively the 20 to 30% of the Indians are hypertensive, and we talk about mainly the systemic hypertension. What I learned is mask hypertension, the white coat hypertension, all these things, potassium, how valuable to estimate it, and what is the role of there is a very small role for monotherapy and combination therapy, more important. How do you follow it up in renal failure and cardiac failure? Fantastic talk. I think we should do a good round of applause to Dr. Prabhakar. We enjoyed it,
Yeah,
and
yeah.
we love to have you many more occasions of in the ACG and as the international webinar. I am very glad that I must congratulate the delegates from all over the world. Over 1,000 have attended this webinar. And Anil, even though initial hiccup was there, he really compensated with his fantastic slides and what is the role of corbitalol, how it is better than propranolol, where do you combine this one, where do you replace propranolol over corbitalol, and you did a fantastic job. It was really one of the best webinar we ever had. And Vivek with the wisdom, with the voice coming around from his throat, and you gave a fantastic thing. And Professor Chandru, he is a role model for the physical thing. You see him, the way he plays the football and the cricket and the lifestyle. He is the role model. He get the first prize among us. And Aravind did a fantastic job, and Praveen. And I enjoyed hosting this. This is the 36th webinar we have been conducting, and it has become so popular because of you people and because of the dedication with which you prepare the slides and the way you do it. And thanks to the Zoom platform that we could do it and attract as many delegates from all over the world. Thank you very much for this wonderful.
Sir, and finally, I need
Yeah,
to
yeah.
congratulate you. Okay, I need to congratulate you
Who is
for
that?
really showing such a talent in bringing up
Yes, sir.
this
Yes, sir.
wonderful academics.
Thank
Awesome,
you,
sir.
sir.
Yes, sir.
All because of we have people like Prabhakar coming, Anil. Prabhakar said when, where, what topic. That's all. Anil said what topic, and Vivek Saraswat said I'm there. And Professor Chandru again he said on all of you ambassadors propagating the message of our webinar. Next webinar is going to be very interesting. Dyslipidemia management and we are going to have a mast disease and various thing about the lipid profile and managing that, and the fat and liver by Gordas Chaudhary, from storage to damage. That's the typic we are given. Fat and liver, storage to damage, and dyslipidemia management by the president of Lipid Association of India, Dr. Narasinghan, is going to talk. Don't miss the talk. The reason is it is going to be a problem, and next decade is going to be the disease of the obesity, hypermetabolic syndrome, and malignancy, genetic disorder. There are 4 diseases. They are going to rule the world is the 4 diseases. So one of them is the obesity, dyslipidemia, and the fat. So with this, I thank you very much for this
Sir,
wonderful.
congratulations, sir. Sir, congratulations. You are making a world gastro family for us.
Yeah.
Congratulations.
We have from Nepal, we have from
endorse.
Nigeria,
Yes.
and this is the very unique webinar because the one word combines everyone is the American
Yes, sir.
College of
Yes.
Gastroenterology, 95 years old organization, ever took taken the responsibility of governor for India region. I have 1,500 members in India and over several thousand members all over the world, and it is displayed in the ACG website also. So I'm very glad that for your cooperation. Thank you very much, Saraswat and
Thank you, sir. Thank you.
Anil,
Thank you.
Bye-bye.
Bhagat,
Thank you, sir.
Sadhru,
Thank you,
Thanks
sir.
for
Yeah.
a very good
Ravi.
evening.
Yeah.
Okay.
Thank you.
Bye-bye.
Bye.